Hi, Catherine Kripke from the Division of AIDS at NIAID. How many people do you estimate are undiagnosed in the United States, and what's the plan for identifying them? What have you learned from the expanded testing initiative in terms of targeting testing and prevention programs?
Great.
Thanks.
So thank you for your question. About 20% of the 1.2 million Americans are unaware of their HIV status, and that really works out to about 240 to 260,000 Americans. So there are a number of strategies that we have in place to address this undiagnosed fraction. I've mentioned some here. Scaling up HIV testing, especially federal funding of HIV testing, in ways that we have not done in the past. And certainly CDC has invested a substantial amount of monies to do this scale up in the United States. The second key strategy is also leveraging other federal resources to do that scaling up as well, recognizing that CDC is not the only player in town, that we need to be leveraging the resources, for example, of the community health centers, who are likely to be seeing people who are at risk for HIV, CMS, in terms of Medicare and Medicaid recipients, ensuring that we have policies in place nationally to facilitate routine HIV screening, as recommended in our 2006 recommendations, removing the barriers to these, and of course, working with providers and communities to scale up HIV testing. So there's a huge and very deliberate strategy on scaling up HIV testing and linkage to care, because both must be in tandem as we're thinking about reducing the undiagnosed fraction in HIV. Now, I think there are many lessons that we've learned from our targeted, expanded HIV testing efforts in the United States. I've mentioned some here. First of all, the importance of targeting. That it makes no sense putting monies out in the communities and not getting the benefits of those new investments in the communities that need those investments most. And we started the HIV testing initiative in 2007, and that was one of the first times that we were able to say, this is the epidemic that we have in the US today. We need to put these new resources for these communities. We began with African Americans, and we subsequently expanded it to include Hispanic and Latinos and gay and bisexual men. We certainly learned the importance of working with the communities at the local level to understand where communities are accessing services, what are the touch points for us to meet communities where they're at, engage them in conversations about HIV testing, and to use the new resources to scale up testing in those culturally appropriate venues. We've learned the importance of partnering with communities in ways that we haven't done before, and building and matching these prevention interventions with wraparound services, including social marketing campaigns, which are culturally competent, community engagement campaigns, working with African American, Hispanic and Latino leaders at the local level to do the community mobilization that results in successful HIV screening uptake within those communities. And the data, which I didn't have time to present, are beginning to show the fruits of these efforts in the US. We've been incredibly successful in not only scaling up the HIV testing, scaling it up in the communities at greatest risk, but also uncovering more undiagnosed infections within the community, which is exactly the objective of that effort. So
thank you so much.
Do you want to switch from mic to mic? You want to go next?
Sure.
Hi, I'm Bob Rohr, journalist, write for a number of folks. We all know that rates of circumcision in this country are falling, and they're lower in Black and Hispanic communities that are disproportionately affected. And part of the reason, part of the explanation at least, is Medicaid often does not cover those. The second idea is that within the last few weeks, the Institute of Medicine had issued a report, and HHS issued guidelines for women in terms of basic prevention services. So my question is anything being done to make sure that a basic prevention package required by health insurers, providers, includes circumcision for men?
That's a very good question. I'm not aware of conversations which are currently being had about integrating or including male circumcision as part of that basic prevention package. And I'd be very happy to have these conversations with my colleagues in the appropriate federal agency to understand and to know whether these conversations are being had. The point you raise about the declining trends in male circumcision is, as you know, well documented in the United States and is potentially a real concern given what we know about the health benefits of circumcision and given what we know about the communities which are likely to be seeing the greatest declines in male circumcision, and of course, given what we know about health inequities in the US. So I think we do need to have new conversations on this. CDC will be releasing recommendations for male circumcision in the United States shortly, and we look forward to engaging the community and our partners on this conversation on the role of adult male circumcision in the United States.
Actually, this is one of the moments where it's like wonderful to get to be on the day here to intervene, because actually the White House strategy specifically excludes perinatal circumcision. And it's been removed from the agenda. And since actually the data came out from Dr. Leibowitz 3 years ago, 3 more states have dropped Medicaid reimbursement of perinatal circumcision. So is this on CDC's HIV agenda, or is it a different part of CDC that will be addressing perinatal circumcision? Because you were very clear to keep your comments to adult circumcision.
Yeah. And again, you know, I don't want to sort of presage what's going to be coming out in the circumcision recommendations. Clearly, again, I will only say that we're aware of the trends, and we are aware of the trends. Yeah, thank you.
Next over here.
Sheldon Fields, Florida International University. And first of all, thank you, Dr. Fenton, for an absolutely wonderful presentation that has laid out what the issues are. As behavioral health scientists, and truly believing that we need to go with this targeted strategy, how do you propose that we do true innovation in a scientific paradigm that is so restrictive and so one-minded that it doesn't allow for the level of innovation that we're going to need to do these demonstration projects in those targeted communities that look different? Because we're getting pushback with some of the innovations that we want to do because they don't quite fit into that very strict scientific box. Then the other question is, as a healthcare provider, within this changing healthcare system that is transforming very quickly, how do we truly open it up so that we utilize our healthcare providers to the full extent of all of their abilities? Case in point, I see a lot of we need to target physicians. I'm a family nurse practitioner. We need to target healthcare providers and working in collaboration with our physician colleagues.
Great questions. So the first related to how do we do things differently now that we know better? And I agree entirely with your comment. So 2 things. First of all, I think the National HIV/AIDS strategy makes it absolutely clear that we need to do things differently. And it challenges all of us to think about ways in which we are doing research prevention programs and looking at policies which meet the needs of communities which are at greatest risk of HIV in the United States today. CDC has been doing the due diligence of changing the way we're developing our prevention programs to align with the national strategy. I know NIH is also having these conversations as well. And I'm confident that in time you will see opportunities that will reflect what I've presented today in opportunities not only for prevention programs and policy, but in time for treatment and care and research. I also think that the recent release of data on these tremendous increases in HIV incidence in young MSM will force a very different conversation across federal agencies about what are we not doing for young MSM and why are we failing to prevent HIV in this young generation of men who have sex with men in the United States. And we're already beginning to have these conversations with our counterparts at the NIH, with other federal agencies. I believe it's going to be a key theme of this National Prevention Conference as we think about some of why the current models are failing communities, and especially communities of color. And I would hope that we would be able to use this opportunity to stimulate that new conversation and to hold federal agencies accountable for demonstrating real change. And that's what's needed now. Thanks.
Thank you.
Victor Martinez with Bienestar in California. As always, Dr. Fenton, thank you for your presentation. I have two questions. One is in regards to the role of the Davis on treatment as prevention. How can we incorporate the role of the Davis with treatment? That's one. The other question is about how to craft a message on treatment as prevention in regards to the Latino community. And the last question is about the social marketing campaign for Latinos. Do you have any update on that?
Great. So, fantastic questions. So the first is, how do you integrate treatment as prevention with DEBIs? I don't think there are conflicts here. I think this is a new prevention tool that needs to be integrated, and we need to think about this as we talk about combination approaches to prevention. So we need to look at the DEBIs, we need to look at HIV testing, we need to look at treatment as prevention, and think about ways in which we're packaging them appropriately for communities who are at risk and for populations that can actually need to benefit from these interventions. So I don't think it's an either or, but I think the real issue is, what do we know about how do we best integrate this new prevention approach into what we're doing with DEBIs? Your second question was around treatment as prevention with Hispanic and Latino communities. Victor, I would argue that we need to have this conversation with all communities in the United States. The results of the trials have only come out within the last 2 months. Right now, I don't think we have, and collectively, started these conversations with communities across the country to talk about what does this actually mean? What does the treatment and care cascade, which I showed, actually mean for the quality and impact of what we're doing with people who are diagnosed and in care in the US? What does it mean for diagnosing, linking people to care, and maintaining people in care? We need to have new conversations, and I would argue that we need to have these new conversations not only with Hispanic and Latinos, but with all communities, but especially those communities which are hardest hit. And then finally, our communication campaigns for Hispanic and Latinos are very much a priority for us at CDC, as you know, with our Act Against AIDS and our 9.5 Minutes campaign. We have provided those materials in Spanish as well, and we worked with communities of Hispanic and Latino communities. We've brought Hispanic and Latino communities into our Act Against AIDS leadership initiative. That's the partnership that thinks about this umbrella social marketing campaigns and ways in which it should be implemented. And I'm hopeful that after the next phase, which we'll be launching at this conference, which focuses on young MSM of color, young African American MSM, that we will be moving shortly to have more Hispanic and Latino focused social marketing campaigns. So we've been doing this in a phased manner moving forward, and this next phase is on young Black MSM, but we're hopeful and focused on and mindful of the needs to social marketing campaigns in Hispanic and Latinos as well. So 3 questions, 3 answers. Thank you very much, Victor.
Thank you.
Only have time for one, I've been told, not my fault, time for one more question. So I'm really sorry, but I will be around for a few more minutes after this, so please.
Thank you. I'm Seth Kalishman from the University of Connecticut, and thank you, Dr. Fenton, for your great talk. My question really has to do with how you envision the role of the CDC in the future of HIV prevention.
Yeah.
I'm reflecting on the 90s when there was a lot of discussion about how HIV testing is really a diagnostic tool, and it should be under the umbrella of HRSA. Well, the CDC did Project Respect to really prove the case that testing is prevention. Now that the CDC has gutted prevention from testing, and testing is in fact a diagnostic tool, and we're looking at really the way of prevention going in the way of treatment, I guess my question is how you envision the CDC staying a player in HIV prevention, and really what's your argument against HRSA doing a better job with HIV prevention?
So, Seth, great question. I won't have time to really give you the full answer that I'd love to, because we're having these conversations currently at the agency. I think there are 3 domains that I think we need to focus on. First of all is continued advocacy for prevention. Treatment as prevention focuses only on the HIV-infected person. And if we believe that there is a role for engaging hearts, minds, and behaviors of people who are HIV negative to keep them healthy and safe and prevent acquisition of HIV, then we have got to focus on prevention. And we have got to keep that advocacy for prevention, not set up a conflict or a dialogue that is saying treatment is better than, or one is better than the other. And that, I think, is a key part of our advocacy role moving forward, that we need to maintain the fact that we need multiple modalities for different sectors of the population for health, wellness, whether you're HIV infected or negative. Second, CDC clearly has to look at how we're looking at prevention and what our model of prevention is, given the evolving epidemic and given the changing socioeconomic circumstances that we're working in. At this conference and before, you've probably heard about our new approach to prevention, which is looking at high-impact prevention, which is thinking about the effective interventions that we have, thinking about the populations which are in need, delivering those interventions at a scale and level to have the impact that we need to have with those communities. And that's essentially high-impact prevention. So that brings to the table issues of combination approaches, how we combine interventions, how we intervene at the right phase of the epidemic, how we ensure that we are giving these interventions at a level to have impact, how we implement our interventions. So that's a clear way in which I would argue in the 21st century we're changing the way we do business at CDC to meet these new realities. And then finally, I think that, again, thinking about the either-ors of which federal agency takes a lead is a non-starter argument in this current environment. The Affordable Care Act really pushes us to think about the different points within the healthcare system and how we leverage those points most effectively. Today, there's far more collaboration and integration between the federal agencies than I have ever seen in my 7 years at CDC. So whether it's our partnership with HRSA, bringing the community health centers on board, or partnership with the FDA, CMS, etc., to think about the system as a whole and not as a sum of parts. And I think that is going to be a real change that we're going to be seeing over time. And part of that change is understanding what are our lanes of competence and doing them and delivering them effectively. But second, ensuring that we're partnering effectively with the other federal agencies for greatest impact for communities. And that's something that I've always been committed to, and we'll be ensuring that that takes place as we move forward. So thanks again.
Thank you very much.
Thank you very much, Dr. Fenton.
Thank you, Dr. Fenton. And we now have a brief break, emphasis on the word brief, because we have, well, this was a wonderful, first let me thank you, it was a wonderful and terrific start to the morning and to the day, and there are many more issues that are going to be required to really think about the implementation challenges that lie ahead of us. So there's coffee, fruit juice, and some snacks around, and let's come back in 10 minutes, please.